Our next speaker will be Dr. Judith Currier, who is a professor of medicine and executive vice chair of research in the Department of Medicine and director of the UCLA Center of AIDS Research. Dr. Currier is a professor of medicine at UCLA, and she is also the Michael and Sue Steinberg Chair of Global AIDS Research in the Department of Medicine at the University of California, Los Angeles. She's immediate past chair of the NIH-sponsored ACTG network and principal investigator of the Leadership Operations Center, LOC, for the ACTG based out of UCLA. Her research focus is in long-term complications of HIV disease with an emphasis on sex differences in antiretroviral therapy, cardiovascular disease, and women's health. Dr. Currier, welcome.
Thank you. I know I'm standing here between you all and lunch, so we'll get into it. This is an absolutely beautiful campus and conference center. I'm really pleased to be here. And I'm going to be talking about new HIV treatments. And it's actually a pretty exciting time in this area. I have served on a data safety monitoring board for Merck. It's my disclosure. I'm going to talk about why we still need new drugs and go through some of the drugs that are in development and where they might fit into our clinical practice and what gaps they might fill. And this is a chart that I updated of all of the currently approved antiretroviral drugs. And some are for prevention on the slide, but it's really quite extraordinary to see the number of drugs that have been approved. And I think people might ask, well, you know, we have this abundance. I feel like this is kind of a seasonal representation of abundance as we approach Thanksgiving of all these medications. Why do we need more? Well, I think we don't have as many drugs for certain populations. And I really want to highlight pregnancy as one of those issues, with the majority of women living with HIV globally being of reproductive age. And also for children, we've really lagged behind in developing and approving drugs for use in children. But beyond that, there are other reasons that we still could benefit from new agents. There are limitations of our current therapies. I think we're all dealing with people gaining weight after starting antiretroviral therapy. While we have one pill regimens, they multiple one pill regimens include 3 different medications, and there may be still yet unforeseen long-term toxicities of taking so many medications. We still have some issues with drug interactions. And for some populations, taking a pill every day is a reminder of living with HIV and leads to challenges with adherence. While it's less common, drug-resistant HIV still exists, and we still have to deal with that. And then I think also, very importantly, the high cost of medications around the world is contributing to access. And with the withdrawal of US federal funding for global HIV treatment, this is even a more pressing issue. So when we think about the different populations, people doing well on treatment, which is really a very large population in the US, people struggling with daily therapy, and people with multi-drug resistance, we can kind of go through how each of these needs fills a different gap. So for people doing well on treatment, cost accessibility is a big issue, but maybe fewer drugs and less toxicity. For people struggling with daily art, reduced dosing frequency, reduced stigma of taking treatment and cost. And then for people with multi-drug resistant, obviously having drugs that are active against the resistant virus. So this is a beautiful graphic from a review article done by Raj Gandhi and his daughter and you'll be hearing from Raj later today. It kind of goes through the life cycle of HIV and helps us look at where new drugs are active. So first, entry inhibitors, we have had approved the ibalizumab and fostemsavir for drug-resistant HIV. And there's a number of drugs in development that are broadly neutralizing antibodies. You heard a little bit about those earlier today in the cure space. In the reverse transcriptase inhibitor category, there are both non-nucleoside and nucleoside RTIs, and I'll talk about some of these, each of these today. In the integrase inhibitor category, there's ultra-long-acting cabotegravir, and in development, two new integrase inhibitors that are, one of them from ViiV, one from Gilead, that's on hold. Capsid inhibitors, we have lenacapavir, which was approved for prevention this past year and has been approved for people with drug resistance. There's a prodrug in development and another capsid inhibitor, which I'll talk about. And then maturation inhibitors, which have had challenges in the development due to resistance or early development of resistance or pre-existing resistance. So this is kind of an overview, but there's a lot going on. I think it doesn't feel like that when you're practicing in the clinic, that we really have a lot new to offer, but there really is a lot. So I'm excited to go through this. And the ones that are highlighted here and their little red asterisks were presented at the IAS conference this summer. So let's start off. In my practice, I have a lot of people who've been living with HIV for decades, and some became undetectable through quite a circuitous path and ended up on some pretty, well, I'm just not proud of the regimens that they're on. Maybe we could say they're just not conventional. And I ask, are you interested in switching? And they often say, no, this is working for me. I'm not going to change. But this artistry study really, I think it's a great study because it took people who'd been on treatment for a long time, who are on multiple drugs, who were suppressed, had no resistance to bictegravir or any prior lenacapavir, and asked if they could, if changing to the combination of bictegravir and lenacapavir, which is not something you can do on your own because you can't get a hold of bictegravir as a single agent, but they looked at this combination, either the 75 milligrams bictegravir with 50 or 25 of len. And the population median age was 60, 27 years on antiretroviral therapy. Most were on 5 or more pills a day. And the suppression rate with this single tablet investigational combination was really non-inferior to staying on this regimen, 96% with either dose. So this is in a phase 3 trial now, so a tablet that includes these together. And I think that there are patients who could go on a simpler regimen with fewer pills if these results are borne out in larger studies. So I see this as really an advance for a large population of people. But in convincing them to think about switching the regimen, I think is another challenge. Another simplified regimen with fewer drugs is a combination of doravirine and islatravir. And islatravir has this history of being studied and being found at higher doses to cause a decrease in CD4 count. But now with lower doses, those concerns are don't continue. So there have been phase 3 trials with people who are suppressed on this combination of doravirine, islatravir versus continuing on bictegravir, FTC, and TAF. And then another study versus oral ART, not limited only to bictegravir. And switching to this 2-drug combination was non-inferior to continuing the previous regimen. And in this studies, the CD4 and lymphocyte counts remained stable. So this is 2 drugs given every day and another option. This was submitted to the FDA for stable switch indication back in July. And we may hear from the FDA as early as the first quarter of 2026. There's also a head-to-head comparison of this combination. So a non-integrase, non-TAF containing regimen for initial therapy. Now, whether this will be associated with less weight gain, I think we need to see, and surely will be an important measure that's included in this study. The results for this are expected next year. So the other issue that we face in practice is the fact that not all people are suppressed. These are data from the CDC from 2023, the last available data that's been made available through CDC at least, showing about 65% are virally suppressed. That seems like a low percentage. And I think in some practices, the rates are higher. It really varies around the country and in the setting, but there's still a gap of people who've been unable to achieve viral suppression despite all the drugs we have. And a lot of hope that long-acting therapy might be what we need to fill this gap. But unfortunately, when long-acting treatments have been studied initially, they've been studied in people who are suppressed. So they don't really address the question about whether they're going to work for people who are not suppressed, although I think we're moving towards now getting more data in that. And I think the other issue about long-acting is that clinicians, and I really include myself strongly in this statement, just did not believe that people would want to take a shot every month or every 2 months rather than taking a pill every day. Coming into the office or to a clinic to get a shot when you could come in twice a year. I just thought for a lot of my patients, they weren't going to want to do this. But every study with long-acting, the people that have chosen to enroll in the studies really find it improves their quality of life. So this was a great survey that was done a few years ago looking at preferences for long-acting versus current oral therapy. And the groups, really 3 groups emerged. Some people wanted an implant, some wanted oral or injection, and about a third wanted just to stay on their current therapy. So it's not one size does not fit all. And I think we need to have more options for long-acting treatment. And things are in the pipeline. I want to acknowledge Malachi Keogh. This is a slide that I got through Raj Gandhi, which really beautifully shows out how to keep these straight, because their names are confusing, they have numbers, and so we're going to go through this. So there are regimens and drugs in development being studied to be given once a week. And you might say, who's going to want that? But there are people for whom that may actually be the best. So once weekly dosing with islatravir and lenacapavir, islatravir and another NRTI, ulonivirine, and then 2 drugs by Gilead on hold. So once weekly dosing, I'll go into some of these studies. MK-8527, which you heard about earlier today, is in development for PrEP, not for treatment at this time. And this is given once a month as an oral medication. So an alternative to people who don't want a shot for prevention. This is in phase 3 trials at this time. Every 3 months, there's a Gilead drug in development. Every 4 months, there's an ultra long-acting cabotegravir rilpivirine. Every 6 months, lenacapavir with 2 broadly neutralizing antibodies, which I'll talk more about. And then there's also a once a year lenacapavir, which is entering development for prevention. And that I think is about to enter clinical trials now. So really there are different options, but mostly for treatment, we're really looking at once a week, every 3, 4, or 6 months. So weekly oral islatravir, lenacapavir, what do we know about that? Well, there's been a phase 2 open label controlled study for 48 weeks. People that were already suppressed on bictegravir, TAF, FTC, and it had to be suppressed for 6 months, had to have a high CD4 count, and that's because they were evaluating this lower dose of islatravir. But they looked at islatravir 2 milligrams with lenacapavir 300 milligrams weekly. And notice in that, when I talked about the lenacapavir daily with bictegravir, the dose was 50 or 75 milligrams, so it's a different dose. And this was compared to daily dosing of TAF, FTC, bictegravir. So this study showed good suppression rates in both arms, really comparable with this dosing regimen, a weekly dosing regimen, and no significant difference in CD4 counts and absolute lymphocyte counts. So again, confirming that this dose of islatravir, the 2 milligram dose, is safe and looking like this may be an option. So this is the first weekly regimen that may be coming along. Now, these studies of islatravir, lenacapavir once a week the phase 3 studies are fully enrolled, and we should have data about this next year. So once weekly dosing. There's also MK-8507. ulonivirine, I cannot say that, and islatravir, which has a long half-life. There's a phase 2b study looking at this combination that showed maintenance of suppression without any impact on CD4 counts. So this is another option that may be coming along. There's a phase 2b study that's ongoing, again, in the stable switch population. The integrase inhibitor GS-1720 and the prodrug of lenacapavir from Gilead are also being studied for weekly oral dosing. These are studies, they're called Wonders 1 and Wonders 2. The long half-life, I think, is sufficient for weekly dosing of these two drugs. But the FDA placed a hold on these trials because, and it was kind of surprising, but a CD4 lymphocyte decrease was seen. And the mechanism of action is not related at all to what islatravir has. So the reason for the CD4 decline is certainly not clear to me. The other 8527 I mentioned earlier, that once a month, this once monthly agent is only being studied for prevention at this time. Its safety profile looks good compared to placebo, and there are these phase 3 trials called Expressive that have started both in the US and globally. And we'll see if a once monthly option is well tolerated and effective. The ultra-long acting cabotegravir, which is every 4 months, is also in clinical trials. And again, this is for prevention, or for PrEP. There is a treatment study that's planned, but I don't know if that's actually started enrolling. And I think it'll be interesting to see whether going from every 8 weeks to every 4 months will maybe increase desirability of long-acting injectables and feasibility in different clinic settings. This islatravir prodrug, GS-1614, and in combination with lenacapavir, is looking at every 3-month dosing. So a lot of activity here. There are also some long-acting integrase or capsid inhibitor from ViiV that's shown to have virologic activity in people who are naive, but there was some emergence of resistance. And then also a 3rd generation integrase inhibitor, which also looks like it may have a long half-life, is being developed for treatment. Every 6-month dosing, I think, is something that people are interested in, and we've seen results from sort of serially results with longer follow-up of the study with lenacapavir, which is given every 6 months, with 2 different broadly neutralizing antibodies, TAB and ZAB for short. Very well tolerated. One participant had virologic failure and had low lenacapavir levels, and the phase 3 studies of this injectable regimen are in progress. So this will be another option with the 6-month dosing interval, which may be easier to deploy in settings than more frequent injectables. This is called the EMBRACE study. So the 12-month dosing of lenacapavir, which is, the early results from the lenacapavir PrEP studies are very exciting. I think we heard earlier today, the cost, it makes it out of reach in many settings. Could this be a once a year? Could this be a once a year intervention? And we'll see. The study's not yet recruiting or just about to start recruiting, looking at this option, but this is for prevention at this time. So if we get new drugs, how are we going to use them? And I think that it's interesting to think about the people that you care for and who would be interested in changing regimens and asking patients about whether weekly, monthly injection, what would be good. So people doing well on antiretroviral therapy, young person who wants to take fewer medications, maybe switching to a weekly regimen. Would be better flexibility. People that are on complex regimens, and I talked about patients who have these messy regimens with boosted PIs and NRTIs, switching to have fewer drug interactions, and especially as they age, issues of drug interactions become more highlighted as people need other medications for managing comorbidities. People with multi-drug resistance, again, this is not as common as it was maybe 15, 20 years ago, but it still happens. And having new classes of drugs that are more than one new class available at the same time, I think is exciting to have available. But I think it is important to pause and stop about and talk about cost and access, because they won't be cost effective if the price is high, and they won't be used. And in what's been referred to this morning as our fractured and sort of crumbling healthcare system and availability of programs that provide medications for people living with HIV. I mean, this really has to be our number one concern, is how can we make these drugs more affordable and accessible to people globally. It's estimated by 2030, 4.5 million people might need second-line treatment and in Africa, and we don't have a lot of options that we can make readily available. And then also more than, as I said earlier, 50% of people living with HIV are female globally, and of childbearing age, and safety in pregnancy is important. So I just want to take a minute to talk about this pregnancy issue, because we've been kind of stuck for a long time in not making progress and getting data on pregnancy as drugs come to the market. And I think this was just so important, and it's very important in the PrEP field too, because these are sexually active young women who are going to get pregnant. And so it has to be included in the development plan at a very early time. And we have to go from this conceptual shift, and there's a phases working group that had a call to action in the last 5 years, facilitating the inclusion of pregnant women in research. Not thinking about them as a vulnerable population, but more as a complex population, and not protecting them from research, but protecting them through research by studying these things and making the drugs available, and not presumptive exclusion, but fair inclusion. And so these groups have really done a lot to think about what's the right framework that can be used in drug development to get the data that we need so that there's not this long lag. And the idea is earlier completion of non-clinical studies, animal studies in pregnancy, and then a rational approach to contraceptive requirements. And as agents get into phase 2 and phase 3, allowing women to make a choice about whether they want to remain on a drug if they become pregnant in the study, to get that data as the studies are going on. And this did happen with the PURPOSE studies, and there has been some data with lenacapavir that's now available. And then PK and safety for all new drugs. I think getting that data earlier is also important. And then for priority drugs, second line antiretroviral, now we do have information about darunavir in pregnancy, not with cobicistat, but with ritonavir taken twice a day, being safe. And then just more strategic surveillance and collecting data from globally so that we have this information. So looking here out on my horizon, this is a horizon in Los Angeles where it was very dark and rainy over the last several days. What's beyond this horizon? So I do think there's excitement that we may have more single tablet regimens with 2 drugs in them instead of 3. And hopefully with less frequent dosing. Potentially, we talked about once weekly, a couple of options being studied for once weekly, and then with some of the injectables every 4-6 months. Drugs that target novel mechanisms with novel delivery systems. Now, I didn't talk about implants. There's not a lot of new sort of early clinical work, but there's a lot of preclinical work that's still going on, and this is an exciting area. And then drugs that are studied in populations that need them the most. So I'd like to end there early. And I really want to acknowledge the people who shared slides with me, particularly Raj Gandhi, Shaheen Lachman, and others who are listed here on this slide. So thank you.
Excellent talk. And again, for folks with any questions, feel free to use the Slido app, fill out a card, or more preferably come up and talk into the mic if possible. As we wait for some questions to trickle in, thank you, Judith. That was an incredible talk. Just wondering, what are some challenges as we're seeing on many of these like long-acting oral ART, which is really exciting? What are some maybe clinical challenges that you might be expecting or concerned about with sort of long-acting oral agents now that we've implemented long-acting injectables for some time?
Yeah, well, I think we haven't really implemented long-acting injectables as well as many of us would want to. I mean, I think it's been really challenging in a lot of practice settings to figure out who's going to oversee this and monitor it. And, everything sort of tends to fall to the provider, and it's a lot to keep track of. But so I think the early lessons from long-acting injectables it'll be easier to prescribe, but the issue will be, how do you manage when somebody misses a dose? How do you redose that? What's the guidance around, redosing and resetting the interval, and how do you manage that? So I think the studies will probably have some built-in approaches to that, but that would be one of the things that I'd be anticipating, is what to do when people miss doses, or develop toxicity. If you take a medication and you get a toxicity and it's staying around for a month, it's going to stay around for a month. So we haven't seen any early signs of things to be worried about, but I think that's also going to be a challenge.
And is there any role to learn from like our TV colleagues in terms of like DOT or video DOT in these situations at all to assess adherence or confirm adherence?
Yeah, I think that's it's a great idea to think about. I think it will also be easier to provide medications in other non-medicalized settings when it's oral, because you won't need all the infrastructure that you do. So being able to do mobile van where you then do DOT and provide treatment right there, I think that's an exciting implementation opportunity for these agents.
And another question asking, appreciating your framework of how to include pregnant persons into these clinical trials. Could you speak briefly if there's any of the trials you discussed are looking at teenagers or adolescents and young adults, and potentially how to advocate to include young adults and adolescents into some of these clinical trials as well?
Yeah, I think that's another group that kind of is nested between the children, the pregnant women as adolescents. And I have to say, one model, so recently the ACTG in 2023 launched a study of tecovirimat for Mpox. And the way the study was designed is it was a randomized trial for people with mild to moderate disease of tecovirimat versus placebo. And there was an open label study of tecovirimat for people with severe disease, for pregnant women, and for children. And it was all the same study, and it was all done at the same time. So it was kind of all packaged into one clinical trial. And I think that ability to try to get data, these different populations all at the same time, was good. Didn't work, but it was at least a model for how we can do a more integrated approach to studying new drugs.
Excellent. Renzel, please go ahead.
Sure. I want to say thanks to all of you guys. These have been terrific presentations. And actually, thanks to IAS-USA for microphones. I know that's been a constant back and forth. And I think it's great to have additional voices here. I want to encourage everybody to step up. And it's just a good way for us to interact, that we're all used to Zoom for too long and for too many of our conferences. My question is about, we used to talk about sequencing of antiretroviral therapy. And then I think all understood, get the best regimen you can and suppress indefinitely. But it's worth thinking about, just the specific question, would ulonivirine and islatravir, in your mind, be an okay agent for a first failure with NNRTI from what we know now, or a first failure with an integrase inhibitor? Just would you think about that? Would that sequencing matter? And how are you thinking about this new, really interesting option?
Yeah, it's a great question. I think it also, I think a key thing about sequencing is also going to be if we can find a regimen that is not associated with so much weight gain, or weight gain in the people who are predisposed to it, because it is not everybody has significant weight gain. That might become a more preferred initial regimen, but it'll depend a little bit about whether, if people have been suppressed on an integrase regimen, and then why they fail, because they generally aren't failing with resistance. When they fail, they're failing with wild type virus. So I think it's hard to say for sure whether that will be an option, and it will depend on why they're failing.
And in that same vein, any concerns you have of having these non-NRTI, non-INSTI regimens that might be becoming more and more popular? Is there any clinical concerns or things we would have? It just goes against like a dogma that we've done for so long, which doesn't mean it's wrong. Just wondering if it brings up any questions.
Yeah, I mean, it was interesting because we were for those of you who are older, in the protease inhibitor era, we were in the nucleoside era, then we were in the NRTI and NRTI and then PI era. And there was a lot of concern about using integrase inhibitors as first-line therapy. I mean, we did a study that was one of the first to use integrase as first-line therapy in the ACTG. And people were like, no, you need to be saving that drug, not using it. So I think we need to use the safest, most effective agents up front, and the timing of when we learn about them, we may have to rearrange our thinking about that.
Excellent. Someone asking about Levi syndrome, and I'm assuming this potentially with the long-acting oral and the CAB ultra long-acting for PrEP. If you could talk a little bit more about Levi syndrome, and do we expect to see this with every long-acting prevention option?
Okay. Yeah. So this is the syndrome of when you develop HIV, when you're on prevention, that acronym, I don't even know what it stands for anymore, but it's basically the delayed detection of seroconversion in people that are on long-acting therapy. And I mean, I don't know, there haven't been that many well-characterized lenacapavir failures yet. I understand there are a few more from the original studies, and I haven't seen the data, but I've heard that it hasn't shown up yet. So I think you have to have a certain number of failures before you can find that they're harder to detect. But this, it did lead to a whole approach of doing viral load and PrEP, and whether that was actually necessary or not. And so I think it needs to be investigated each time there's a new drug, because we don't fully understand what the mechanism is.
Okay. A slated AI question. So do you see any hope or role of AI being used to optimize treatment regimens in the future? And I would even add to that sort of clinical implementation of newer agents as well.
Yeah, I mean, I think interpreting resistance testing is something, that we have we have good sources of data for, and helping, I think AI can read those algorithms probably faster than I can. I mean, putting all those mutations into the database, it could probably do it pretty quickly. I certainly would want to make sure you're using a validated model, but I do think it is, I think as people have regimen failure, we do have to study what they're failing with. And I don't think we know yet for some of these newer NNRTI combinations what they're going to be failing with, and if it's different than what we've been seeing with integrase inhibitors. So, but I think AI, definitely could help.
Certainly. Any other questions folks may have or would like to ask Dr. Currier this talk? I think one last question that came through was looking at older adults living with HIV. So we had a great talk on thinking about geriatrics and the role of how some of these new agents are in trials may be including or thinking about older adults as well.
Yeah, I think that, I mean, if you look at the stable switch studies, they do tend to have a slightly older population because they require people to be suppressed on treatment for longer. And so I think there is some data. I know all the companies, are starting to do more focused subpopulation, either analyses of their data or specific studies. I think we heard in the aging talk about, safety of Bictegravir regimen in older people. And so I think people, as they try to position their drugs and say this one works best for this population, you got to have some data. So really starting to look at whether there are regimen differences.
Excellent. Norma, please go ahead.
And to that end, any hope for the terrible dearth of menopause and HIV treatment, especially with these newer agents?
Yeah, thank you for raising that question. I think there has been a resurgence, or not a resurgence, a surgence. There was never a surgence, it's not a resurgence. It was never a priority. So more interest in menopause in women living with HIV. And the use of hormonal-based therapy, there's a study that's getting ready to open that's going to look at management of hot flashes, but also management, whether there are differences in regimen tolerability. Weight gain certainly has been associated with menopause, the people that are at highest risk of weight gain, women more so than men, and women of the menopausal age where weight gain is a common phenomenon as well. So I think having more specific data on this population hopefully will become a priority.
I was wondering if you've changed the way you talk to your patients about the risk of being on multiple drugs. So much of our time, I feel like, is reassuring that drugs are safe. And now to convince a patient that they should be on 2 instead of 3 drugs when they feel fine and it's working well, I think it's kind of hard to like cross that line of saying, no, this is safe, it's long-term, and then actually we better get you off this because you're on 3 drugs, let's get you on 2. How do you approach that with your patients?
Yeah, that's a good framing of thinking about. I mean, I think as we get new information, we need to share it. And I think a lot of us were really concerned that 2 drug regimens just wouldn't be as good as 3 drug regimens. But I feel like now we have a lot of data to suggest that they are. And we do have data to suggest that tenofovir and TAF, have their weaknesses or toxicities. And we don't know over 30 years if those are going to accumulate more. And so, for people that are on for example, dolutegravir, TAF, FTC, switching to 2 drugs, I think depending on their insurance, is it really going to cost less? I'm not sure. That varies. That is one argument, that it would be saving money if they have to pay for it. And could there be less long-term toxicity? We don't know. And so I really just share what we know and the fact that we're learning more and give people the option. But in a lot of in my practice, a lot of people that have what I call hard fought won suppression over, were around in the 90s and mid to late 90s, they just don't want to switch. And sometimes you just keep coming back to it and say, when you're ready, we have other options. And sometimes they switch and they're really happy. But it's just, and I think it's just a population that has a different perspective on the whole thing.
Yeah, I've always heard like the car analogy, like some patients just like the car they got and don't want to upgrade, and some patients are always looking for the newer car.
Right, the new cup holder.
Excellent. Well, thank you so much, Dr. Currier, for amazing talk and exciting Q&A. We'll be going on lunch break right now, and lunch will be served out there. There are some seating areas there. You can also bring your lunch back and have it at your desk here. And we will resume our program at 1 p.m. So just a little over an hour. Thank you all. Thank you.